Welcome to Tea Time. I'm your host, Dr. Andreas Plackis, and we are going to cover in this episode, episode 8, the newly implanted heart valve, a SLICK or S-L-I-C-K evaluation. We are going to cover in this episode the newly implanted heart valve. And you'll notice some new colors because this is the first episode of our new valve series. So whenever you see these colors, we're going to be going over something important related to valvular evaluation in a cardiac surgery operating room. The clinical question we're going over today is how can you quickly and thoroughly assess a newly implanted prosthetic heart valve during a cardiac surgery case? And of note, we're going to be covering stented bioprosthetic or mechanical heart valves. So there's a lot of different types of valves out there, but the main focus of this episode is on those two valves, not necessarily on stentless, homograft, autograft types of valves or any other. In this episode, it's a big picture evaluation. We're not going to get lost in a lot of details, but say what is a system that we can use to quickly and efficiently assess a new heart valve, which is what some of the best providers you'll see can do. One way that we can do this is with systems and checklists. We have a lot of things we need to look through, but if we have them organized in a systematic way, we can do this more quickly. Also, during high pressure cases where you need to have answers quickly, systems and structure can help you maintain your focus better. We simply need to focus on what questions require answers about the valve to make sure the valve is functioning well enough that it is safe to proceed with protamine and remove the cardiopulmonary bypass cannulas. I mentioned we need to know what type of valve was implanted because there's numerous different types of valves, and a lot of these have different echocardiographic characteristics when you're evaluating. We're not going to focus on all these valves, but simply focus on the bi-leaflet mechanical valves and stented bioprosthetic valves for this episode. When does this SLICK evaluation that I'm talking about even start? Timing begins right after the aortic cross-clamp is removed. That is the first time that the aortic valve will start to see a back pressure against it again. And if there is an aortic valve intervention, that's when you can start to assess for a paravalvular leak at the aortic valve position. That's really all you can do until you're off bypass. But other things that I do during this time is I communicate with the surgeon to ask if there were any problems with the valve even going in. Sometimes this will clue you into an area of focus about where you need to look when you're performing TEE. I'll also obtain a mid-esophageal long axis view between when the cross clamp is released and when we come off cardiopulmonary bypass to assess for air in the left ventricle. It's also a view that you can see the mitral valve and an aortic valve together, and you can assess to see if complications may have affected each other. You also want to wait until you are fully off cardiopulmonary bypass until you do any further evaluation. When you have abnormal flow conditions, abnormal preload, and many artificially created hemodynamic conditions, you need to wait until you are off to get a true assessment of the heart. Obviously, this is not an English podcast, but the definition of SLICK is impressively smooth, efficient, and apparently effortless. That is the way I want your exam to be after a patient comes off cardiopulmonary bypass when looking at a valve. That's also the way I want a valve to be functioning. I want it to look effortless, efficient, smooth. I want blood to flow that way through the valve. So that's why the word SLICK is important and a good memory tool when thinking through this system. So I want you to remember, a SLICK valve is a functioning valve. A SLICK valve is a functioning valve. One more time, say it with me. A SLICK valve is a functioning valve. We're going to go through each part of this, but essentially the S stands for sewing ring. The L stands for looking at the leaflets. The I for insufficiency. C for any collateral injury. And then K, looking at kinetics. This essentially is a systematic way that we can look at valve structure and function and any other associated conditions with the heart. Let's start by looking at the S, the sewing ring. The big things we're going to assess when looking at the sewing ring include, is the valve well seated and secure, or is there rocking or instability that can be appreciated on echo? You'll look at this top image and you can see they performed a mitral valve and an aortic valve replacement. And the mitral valve appears very stable. It's not moving significantly. It's not rocking. It is well seated. And when you look at this aortic valve that's been replaced, you can notice something very different, that you see this rocking motion occurring. And when you put color on this in the mid-esophageal short axis, you'll notice a significant paravalvular leak present as well. Sometimes with the heart motion, looking at either one of these valves, it can be tricky to assess if there is rocking or dehiscence of the valve, but frequently you'll see a paravalvular leak associated with it. So that can be one way to confirm if you're seeing what you think you're seeing with just 2D imaging. The next part of the SLIC evaluation is looking at the L, leaflets. Is there normal leaflet excursion and movement? When looking at the leaflets, you're basically assessing, is there normal excursion with normal antegrade flow? Do they open and close appropriately? You can see that with the mechanical bileaflet valves or the bioprosthetic valves. It's black or white. Do they open and close appropriately? When they don't open appropriately or close appropriately, it can be much more obvious. You can see high gradients when they don't open, or you can see significant intravalvular regurgitation if they don't close properly as well. You'll see in some of these images different views of when a bileaflet mechanical mitral valve was implanted and one of the leaflets was not moving well at all, and you see significant intravalvular regurgitation with that, and it's also confirmed on 3D imaging as well. The next part of the SLIC valve evaluation is looking at I, insufficiency. Part of assessing insufficiency with these valves is looking at both normal expected jets and pathologic jets. We can differentiate between these two types of jets by looking at the location, severity, and do we expect this jet to be present or not based on the type of valve. Frequently, I do this by looking in the mid-esophageal four-chamber view for a mitral valve and scanning every 30 degrees from 0 to 180 degrees to assess for intravalvular or paravalvular regurgitation. For the aortic valve, I do this in the deep transgastric view where I obtain the view at 0 degrees and scan every 30 degrees through the valve to see if there's, again, any pathologic intravalvular or paravalvular jets that I don't expect to be there. I do this with a zoom function for the aortic valve because frequently it's in a far field of view. One thing to note is when you're using TEE, that posterior side of the aortic valve can be easier to see, whereas the anterior side of the aortic valve can be harder to see in purely mid-esophageal views. So take it with a grain of salt that it can be harder to rule out anterior PVLs when assessing the aortic valve in mid-esophageal views. Anything that's trace central for a bioprosthetic valve, or what's called washing jets for these mechanical mitral or aortic valves, can be present and normal. So what characteristics help define some of these? We define these by jets that are short duration, low velocity without significant aliasing, which will make them look like a uniform color, and also a low length, less than 2.5 centimeters. These washing jets can be known to occur in mechanical valves to prevent thrombi at sites of stasis of the valve. And they frequently occur at where the leaflets close and meet the housing or at where the hinge points of the occluder are present. Let's look at some of the pathologic jets that can occur as well. These can be broken into central and paravalvular pathologic jets. Some of the features that can differentiate these from normal jets are that they're deep penetrating, higher velocity, non-homogeneous with aliasing or turbulence. There's also a pisa in the proximal chamber where the jet could occur, and then anything happening outside the sewing ring, so essentially a paravalvular leak. As far as the central pathologic jets, we're looking to see if leaflet function is adequate or inadequate. Anything mild or greater, especially if it's eccentric, should be considered abnormal. We want to make sure those leaflets are working well before we consider leaving the operating room, and specifically before giving protamine. The other type of abnormal jet that may occur is a paravalvular leak. These are more common in mechanical or percutaneous valves, and you'll frequently see a jet originating outside of the sewing ring. It's not uncommon that you may see some of these jets during cardiac surgery cases. 5 to 20% is what's been reported in different studies. Many of these jets will be seen as trace or mild PVLs, and these are often more clinically and hemodynamically insignificant and tend to improve over time. However, the moderate to severe paravalvular leaks are something that should be readdressed in the operating room setting. The same methods that we use to assess native valvular regurgitation we'll use for these prosthetic valves, both intravalvular and paravalvular leaks that we may see. However, it can be much more difficult to use these same tools because of acoustic shadowing, reverberation from the prosthesis. So it's challenging, and you sometimes have to be creative or use off-axis views when assessing. How do we define some of these paravalvular leaks and the extent of the severity? Some of the criteria that's out there are looking at the circumference of the sewing ring. Anything greater than 30% falls in the severe category, whereas anything less than 10% is in the mild category as far as the circumference of the sewing ring that the PVL occupies, and anything in between that, the moderate. As I mentioned already, trace to mild PVLs are oftentimes left alone, whereas moderate to severe PVLs frequently require re-intervention in the operating room setting. Some of the options for management for these are to give protamine and monitor for improvement, as sometimes those small leaks will become plugged with platelet and thrombin aggregates, and that's how they improve over time. Whereas some that may not improve with protamine or are more severe in nature require the surgeon to go back on bypass and perform a pledgeted suture repair, a surgical repair with a patch, or even take the valve out and redo it in extreme cases. On to the C in the slick valve evaluation. C stands for collateral injury, where we're going to look at the other valves, coronaries, ventricles, and other parts of the heart to see if there was injury to these structures. I do this next in my evaluation because this is the next thing that may obligate us to return to cardiopulmonary bypass and fix whatever problem was created. You'll see in some of these pictures that many structures of the heart are close together, and putting sutures or intervening on one could easily create injury to another nearby structure. For example, in mitral valve cases, you may see aortic valve injury during a mitral valve replacement, changes to LV and RV function, LVOT obstruction, or even coronary obstruction that can occur if a suture goes through a left circumflex artery. Whereas in aortic valve cases, you may see injury to the coronaries, VSDs, changes in LV and RV function, or a mitral valve injury, since those two are very closely related. You'll see some examples of this here where a mitral valve replacement led to an injury to the aortic valve. Because these two structures are closely related, you see how the anterior mitral valve leaflet is very close to that non-coronary cusp and left coronary cusp of the aortic valve. It would be very easy to put a suture a little bit too far and injure one of those cusps during mitral valve replacement. You may also see a left circumflex injury during a mitral valve replacement, as we saw here in this case. You see that inferolateral wall really not thickening at all, and that would be indicative of the left circumflex injury if you're coming off pump and you see this. When an AVR is being performed, you're close to that interventricular septum, and you may see a VSD when you're coming off pump. And also, as we mentioned, that because the mitral valve is in close proximity to that aortic valve, you can see a mitral valve injury as well here. And you don't see this image with color on the right, but what you can see is there's very minimal coaptation to that mitral valve, as that anterior leaflet was retracted significantly during the aortic valve replacement. The last part we're looking at when we think about a slick evaluation to see if a valve is functioning well right after we come off cardiopulmonary bypass is to look at the kinetics of the valve. When we're looking at the kinetic aspect of valve evaluation, we're thinking about the motion through the valve. And both sides of my family are from Greek descent, so I'm probably disappointing my ancestors by how I say this word, but kinetics comes from the Greek word kinetikos, which means of motion. So thinking about motion through the valve, we'll be looking at the hemodynamics, which includes gradients, velocities, the dimensionless index. And this part of the exam, like the other parts, is very important to make sure you are fully off cardiopulmonary bypass when you do the evaluation here. If you have high gradients when you come off cardiopulmonary bypass, there could be a variety of reasons that contribute to that. Looking at 5 different options for why you may have a high gradient can help you in evaluating the valve itself. The first one is looking at measurements. Is your LVOT or aortic valve diameter measurement off, or is there contamination from other valves of your continuous wave Doppler, such as from a mitral regurgitant jet? Next, you'll look at your math. Are you misusing a simplified Bernoulli equation because there's actually LVOT turbulence as well? Or are you in a high cardiac output state as you started inotropes and your heart is functioning very well as you come off cardiopulmonary bypass? Thinking about the physics, could there be pressure recovery, which is frequent in small aortas or mechanical valves? As far as choices, was a poor valve chosen, and you may have patient prosthesis mismatch. And lastly, and the most important thing you really want to rule out is there leaflet or valvular obstruction? Was there technical mishap with a suture or a defective valve or something around the valve that may be impairing its function? You could spend a whole episode here focusing on just this part, but again, this is a big picture episode of valvular evaluation. So these are some of the things we're thinking about quickly in our head when we come off cardiopulmonary bypass. Some of the practical clinical tips here, if you're having difficulty evaluating the valve, use the zoom function, as that will give you better resolution when you're evaluating the valve, especially if it's in the far field of your echo view. And also use the slow motion function, where you can use the trackball to see different frames of the valve and how it may be functioning, especially if a patient's tachycardic and you're having trouble seeing a very specific frame. Also, multiple views, multiple planes, even off axis if needed, can be helpful. Just get creative here and work towards what you need to see. Lastly, don't be afraid to call for help. A second set of eyes and a second set of tools and skill sets can be very helpful in looking further and getting confirmation on your findings, or someone seeing something different that you're not seeing. Take a screenshot of this if you want to have it for intraoperatively when you evaluate the valve to make sure you don't miss things. But a slick valve is a functioning valve. We want to remember that so we can perform things quickly and efficiently when we come off cardiopulmonary bypass in a valvular replacement or repair case. Some of the key points that we're going to remember, I've already said this too many times, but try to be systematic about your approach. A structured, efficient approach is the best way to not miss things, but also perform quickly so you can give protamine, remove your cannulas, and you can proceed with the case if it's safe to do so. Also, know your valve types. Knowing what is expected and what's abnormal will serve you greatly to know if further intervention is required or if everything's expected and normal as you thought it would be. Lastly, the slick valve evaluation is just one way that you can go through this quickly, miss less things, perform more efficiently. A slick valve is a functioning valve. As far as the next episode we're going to cover, it is episode 2 of our valve series. And episode 9 of the podcast, we're going to be talking about native valve evaluation, essentially an overview of the 6 types of things that we're going to look at anytime we look at a native valve to see if intervention is warranted. Thank you guys for watching. If you want more of this content, feel free to hit the subscribe button and leave us a review. Also, if you do something different at your own institution, leave us a comment. It's best when we can all learn from each other, and if you share your thoughts and experience, we can all grow together. But I appreciate you guys watching. We'll see y'all next.